45 years old, the male patient, normotensive, not diabetic, post-renal transplantation, 3 years, but no hypertension before, referred for us for cardiac assessment. The patient hemodynamically stable, blood pressure 140/90, pulse 63 per minute, the ECG showing marked LVH. This is half standardization. Okay. Anyone can comment quickly with seconds because I have a time. Here, it is a marked concentric LVH. Okay? No history of hypertension before. Only post-renal transplantation. Also, this mitral valve, this aortic valve triumphant, no aortic stenosis, no coarctation, there is no, so this unexplained left ventricular hypertrophy. Unexplained left ventricular hypertrophy. Here, so the mitral valve thickening. The patient also has mitral regurg. Well, also tricuspid, yes. Also tricuspid. Here, it is also, there is acceleration here in the cordy, and there is infiltration also in the cordy. There is infiltration also in the cordy. This marked LVH. So, this case, sorry. أنا عملته أول حاجة marked LVH. يا سمحت, excuse me. تعال على الكلام ما بيجيش ليه. الفابي this is the most prevalent, it is lysosomal storage disease. It is one of restrictive cardiomyopathy and also hypertrophic cardiomyopathy. It is due to enzyme deficiency في enzyme alpha galactosytase enzyme. This will lead to accumulation of glycosphingolipids. It is lipids will be accumulated in the blood vessels and the myocardium and affecting cardiac, renal, skin. Cardiac involvement in Fabry disease will lead to left ventricular hypertrophy, can affect also the muscles, leading to restrictive cardiomyopathy and shortness of breath, also can affect the conduction system. Some patients with Fabry, one of them has a pacemaker, I will show for you, can affect the conduction system and causing heart block, also can causing arrhythmia. And one of the causes of arrest in the patient was Fabry due to cardiac arrhythmia. It is due to the deposition of sphingolipid. Also the patient has an affection of cardiac valves, mitral and the aorta. Also can affect the skin, it is very common. It is very common to see the patient, this is skin manifestation. It is vascular papule, it is angiokeratome. So the patient Fabry disease will be suspected in the patient with unexplained left ventricular hypertrophy, patient with renal failure, and the patient with neuropathy. Also, this patient will be presented by neuropathy, upper and lower. And the cardiac involvement will start in the third or fourth decade. Most of them above the age of 30, above 30 or 40. It is a brother for him. It is a brother, another brother for him, on hemodialysis only. It is also a right ventricular hypertrophy. Marked LVH. It is a mitral valve mechanical prosthesis functioning good. I have many pictures, but I don't like to present because there is no time. It is aortic valve, and also this is a pacemaker. So the patient of Fabry disease also can presenting with heart block. Okay. So what is the benefit from the Fabry? Before I work in cardiac center, I saw only cardiac patient, valves, aortic like that, ischemic only. But the infiltrative disease or heart failure with preserved ejection fraction, I found only I'm taking draining only in secondary hospital. After 1 week from the patient, another patient, 90 years old, came to the ER complaining from abnormal gastric pain, tremors like that. You know, in the ER, ECG, if you're complaining from ECG done for him. Calling me, the patient has ischemia, SCD segment depression. 19, cardiac enzymes are normal, you auscultate and no auscultation. To admit the patient, and I will come to see him. I saw many patients. This patient will be this acidic, patient not acidic, patient sedentary life. He's only a smoker. I found here it is LVH, unexplained LVH. Dr. Hassan agree with me? It is unexplained LVH. No mitral regurg, no aortic regurg. So this patient I screening, sorry, ECG for him, this is very important. Is ECG not only the LVH, but also there's a bradycardia. Also the bradycardia, I think this patient infiltrative also. So So I send for hematology for screening. I forget for the Fabry disease, we'll send for enzymes. Alpha galactosidase enzyme in male. In female must be genetic. In female must be genetic. So please don't forget hypertension. So don't forget heart failure with the reserved ejection fraction. It is about 50%, not 5%. This patient underestimate, all underestimate. The Fabry disease, it is preventable. If you treating early, can prevent complications. And now the enzyme replacement service in Fabry disease available. We're taking the patient 1 dose every 2 weeks. Available here, but must be by hematology. It is, I collect, it is very nice picture. It is my picture. I will be repeated again. It is a differential diagnosis of hypertension with the reserved ejection fraction. And I will comment later on. I will comment one by one quickly. It is clear. It is hypertrophic cardiomyopathy. And I have the patient with 2 6 time. It is a patient with hypertrophic non-obstructive cardiomyopathy distal time. This is presented here is a little bar. It is a patient, female patient, 60 years old, came with shortness of breath, lower no BDM, and that's how dilated abnormal fetal motion. I will see you later on.
Thank you for the nice invitation and pleasure to be among colleagues and elite group. This is my presentation, and this is a 37-year-old Saudi male, heavy smoker. For 1 year, he had recurrent DVT affecting his left lower limb. He mentioned he needed large doses of warfarin, but he stopped his warfarin 6 months ago by himself. And lately, he's complaining of some claudication affecting his left leg more than the right. He was admitted in Al-Zahir Hospital end of 219, and with chest pain for 2 days. Already there is waves in the anterior leads, and he came to us in King Abdullah Medical City, and he had an angiogram. He ended with PCI to LAD, which was good. Next day, he had an angiogram, and clearly severely impaired LV function with large apical thrombus. And he was put on the usual medication, and at the time we thought that he had some sort of thrombophilia or vasculitis. So consultation to hematology or rheumatology team, they go along the history, and they mentioned there is no family history of thrombosis, and they sent several hematological and rheumatological tests. Some of them they sent nationally and internationally, and this is the list of so many tests. Some of them are positive, and COVID pandemic, and we lost the patient. Everything went into chaos, and then I will speak about the rheumatology. The rheumatology, they followed him for several times, telephone calls, visits, whatever. At one point, they gave him prednisolone, thinking it could be possible vasculitis. He had poor compliance and response to treatment. And towards the end of 2020, they said there is no evidence of vasculitis and no need for prednisolone, and they discharged him from the rheumatology clinic. The hematology people, they saw him again. They went along the history and also examined him. At this time, they found there is weak pulses, more on the left than the right, and his INR is a bit low. And they reviewed the hematological test. By that time, all the results are there. And they mentioned the one is this, he does have some sort of factor V Leiden deficiency or mutation in one allele, and he's a heterozygous carrier. And then the protein S, protein C, and antithrombin. And they plan he should have anticoagulation for life, and especially with the LV thrombus to keep on warfarin. And he needs vascular surgery consultation because of his left lower limb pain and loss of pulses. Anyway, this is about factor 5 Leiden mutation. It is something to do with genetics, and it is no risk for venous thromboembolism, and there may be also some sort of other genetic and environmental factors which can also lead to thrombosis. And they mentioned he should have counseling and family screening. The vascular team, they saw him, again, they went along the history, and what they found that there is no palpable pulses in the left lip and very weak in the right one, and they plan for CT scan for his legs and his abdomen, and they want also to rule out what they call May-Turner syndrome. And this is the CT, and the result showed that there is some sort of aortitis, and there is severe narrowing in both iliac arteries, especially the left one, and also there is abnormal anomaly or in the celiac, affecting the celiac trunk, common hepatic and common celiac trunk as well. They saw him, but he lost for follow-up for a while, and then eventually, towards the end of 2020, they admit him at the daycare, and they did bilateral angioplasty with kissing stents to both left and right common iliac arteries. And okay, so what we know about the LV thrombus etiology, that it is really never heard of in a normal LV systolic function. Usually it is associated with malignancy, inflammatory condition, blood dyscrasias, and prothrombotic states. But post-MI is the commonest cause we face almost. And pathophysiology will go with the blood stasis, endomyocardial inflammatory injury, and the hypercoagulatory state which happened after MI. This is a study from Australia, a prospective one, and they did to determine incidence and predictors of LV thrombus formation. They use echo and MRI, and they did this at the beginning about 4 days, and 8 weeks later, they repeat the study, and also to determine the rates of stroke and systemic thromboembolism. This is the number of patients. Eventually, they end up with 210 patients included in the study, and both patients, they are very similar, but out of the 210, only 26 were having thrombus, and they find the difference in the loop diuretics and the mineralocorticoids, and what is standing also out is the cases of anterior MI, more prevalent with the patients who had LV. So they could detect the incidence of LV thrombus by 13% or nearly over 12% of the patient, and LV thrombus is by echo is only 6.2%, which is about 50. So all patients who had thrombus detected on echocardiography also had it in CMR. The majority of patients, they have the thrombus at the beginning, and there is 4 patients or 15% who are detected later on. And in conclusion, they said the MRI is the best, and echo also is good, but sensitivity is low and specificity is high. And the fact that you can perform a study later on, you can detect in a small percentage of patients, again, the presence of LV thrombus. High risk factors: anterior STEMI, LV dysfunction, presence of microvascular obstruction, and adverse LV modeling. And the risk of stroke is always there. This is our own study. This is a retrospective. We conducted it in our medical city. And I think we looked at all the data in our database for those patients who had MI, and we are able to evaluate like 3,084 patients between the period 2016-2019, and we divided in 2 groups. which one with LV thrombus and one without. And we reviewed all the notes and data and everything. And we find that the overall incidence of LV thrombus is about 8.4%, and it's more or less the same with even we compared it with the pilgrims who attended to Mecca during that period. Mean age is more or less the same, and no significance between the two groups regarding their demographic characteristics. And we find that those who had coronary thrombus aspiration, they have higher percentage of LV thrombus than the others. Also, those who had cardiac arrest, they have more possibility of developing LV thrombus. This is another one. Okay, this is the same, and again, also we conducted the same, and that LV dysfunction is associated, and the anterior MI is one of the factors. In conclusion, LV thrombus is relatively common occurrence in patients with MI, especially those with anterior STEMI and low ejection fraction.
Dr. Hassan, thank you very much. We are came to the end.
Okay, so this case actually happened 3 weeks ago when I was on call, and a fellow with me from ER, at the middle of the night, she sent me some echo loops. We will see it in a minute, but this is a clinical background of the patient. He is a young gentleman, obese, smoker, otherwise medically free. He had a sudden onset chest pain and a severe shortness of breath. That is why I came to ER. Was tachypneic, tachycardic, hypotensive, and he had some ill-defined soft systolic murmur at apex, bilateral crickets, and he is very orthopnic. He cannot lie flat at all. So this is me, and you see there is something up and down here in the mitral valve. Also in zoom view, we see some up and down, and but in the parasternal long axis, the picture is a little bit different from the fourth chamber. We have some bulky area here, we don't know. And we have some eccentric MR, which could be underestimated, especially the acute MR. We should not depend on the jet. And we have also small pericardial effusion. So the same thing also. Here the MR is very eccentric and swelling. Here the short axis, again, is a little bit confusing, not going with what I thinking of. So this is a ECG. We have some non-specific STT changes in the inferior leads, and I asked her to do posterior leads. As you know, the CERC MI or posterior MI can come with normal ECG, so she ordered also, this is V7, V8, V9, but surprisingly, there are no convincing ECG changes of posterior MI. And this is chest X-ray. Clearly, we have some pulmonary congestion. This crowded area, we don't know what we are dealing with. And this is labs. He has some leukocytosis, BMB a little bit high. TROP-I also positive, but is not that high to explain pulmonary edema in this picture. Some renal impairment. My thinking at that time, we have pulmonary edema, we have acute MR, but we don't know what is the cause, and whether there is any cause or not, we'll see later on. So what to do at this stage? I told her, prepare the patient for transvagal echo. I will come to do echo in ER, transvagal echo in ER. So for the sake of time, I will go to show the TE. So again, I see something jumping in and out, up and down, and I see clear eccentric MR with reversal, clear reversal by color and by Doppler in the pulmonary vein. So undoubtedly, the patient has MR and has something here. But when I came to the four-chamber view, the picture a little bit different. We don't see rupture papillary muscle as I thought, and many of you thought of the papillary rupture, I mean muscle rupture. Also here, we see some, the anterior leaflet is okay, but the posterior leaflet, we don't see it, and we don't see rupture cordy or anything, something like that. Here, zoom view on this area, I see some collection, some mass, something like that, very thick, maybe bleeding inside this area, also the MR. So I did some 3D cropping quickly because the patient is unstable. So we see this is surgical view. The quality is not very good, but anyway, we see bulging posterior annulus is bulging, but we don't see rupture cord or papillary muscles. Also here in the glass view and true view, we see the MR and we see the bulge of the from down the posterior wall itself. The annulus is bulging inside the mitral valve. So as I go down, I'm finishing the T, doing the aortic view, transgastric, I saw this circular mass with some look like flap in 3D also. Clearly to me this is dissection. So I asked for the CT. While I am asking for the CT with this impression of dissection, query dissection, I went to look for the contrast. It is 2 a.m. in the morning. The pharmacy is closed. Anyway, somehow I found contrast to rule out that collection is not, I mean, like free wall rupture or something like that. So I don't see a clear, convincing escape of the contrast or shunt or something like that to explain this one. So while waiting for the CT, I thought I will do 3D, more 3D views for that lesion. So I flip it up. I flip the picture up, the mitral valve is here. So I'm interested in this area. And as you see, in this area, it looks like a cystic mass with some small masses inside that mass. So at this point, I went to the CT radiologist by myself. I woke her up from sleep, and I told her I need to look to the CT images. So in the heart, she told me that we have a heterogeneous mass, something like that, masses at the posterior leaflet pushing the mitral valve, but nothing more than that. I told her I am seeing what looked like dissection, something like that. Yeah, and so when I went back to the also, why I went to CT, because you see this one, I see it is outside the heart. So I asked her to look to the liver. Is it in the liver? Is there anything looks like this one? So she told me, yes, exactly yes. So this what exactly what I saw behind the heart, posterior to the heart, this one, with the septum very clean. And there is another one cystic here. So at this time, I thought of hydatid cyst of the liver and the heart, the one in the heart rupture into the pericardium. I went back to the patient and he gave me very clear history that he has what looked like anaphylactic reaction. كأنه موية حارة تصبت على جسمي. I have severe itching. I have severe shortness of breath, some fever. He's a farmer and keeping animals in his farm, something like that. So no doubt this is hydatid disease, which is rupture and causing pericarditis with some pericardial effusion, distorting the posterior leaflet, causing MR, and this is anaphylaxis, hydatid cyst in the left more than the right side, and the treatment of this one, if you have anaphylaxis shock, the treatment is epinephrine. If you don't have anaphylaxis shock, the treatment همازول زي ما بقول بيسموه البندازول. Okay, so we refer this patient. We call the cardiac surgeon in ER because it is distorting and rupture in the pericardia. The cardiac surgeon declined the case. We refer him to thoracic surgery. Thoracic surgeon say and maybe they will deal with the liver. Thank you very much. So the whole message, just take broad mind, thinking. Sometimes you need to think outside the box, and detailed medical history very important. And that